My name is Gregory, and you can catch us every Tuesday night from 7 to 8 p.m. here on Charter Communications Channel 280, also on Globecast Systems, and you can always find us on the web at www.glendaleadventist.com/healthline. We just spent some great time with Nurse Callie Balkman talking about what happens in the ER. And I'm very fortunate to have my next guest, Dr. Anthony Cardillo, who is a doctor at Glendale Adventist Medical Center Emergency Department. Welcome,
Thank you.
Doctor.
Thank you for having me.
Thank you for being here. Tell us what it is you exactly do in the emergency department.
I'm a physician, and my primary responsibilities are to work in the emergency department. Just to step back for a moment, the specialty of emergency medicine was founded in the late 70s into the early 80s because there was this tremendous need to provide acute care to patients that were having acute life-threatening illnesses. Before that, there was just this room somewhere in the hospital where all the sick people wound up, and most of the doctors that didn't want to work on the floor or in the operating suites actually wound up working down in this room. And actually occasionally the doctors that weren't able to work upstairs for other reasons were kind of sanctioned down to that room. And that's where all these people wound up, these very sick people. Over time, that room got bigger and bigger, and the people coming into that room got more numerous.
Sure.
So medicine, as the world of medicine, decided that there needed to be another specialty. A specialty where physicians would train specifically in taking care of the acute and critical needs of ill people. And thus was the development of the specialty that we call emergency medicine. Just like you have different types of surgical specialties, whether it's plastic surgery, orthopedic surgery, or heart surgery. In the world of medicine, we have internal medicine, pediatric medicine, and so on and so forth, and now emergency medicine. Very well-trained doctors to focus just on acute care.
So then you were trained to make a decision like that.
Exactly.
How hard is that?
It's very challenging.
Are there moments where you know you have to make that life choice, that decision?
Yeah, almost every day. And originally, that's what sort of draws you into the specialty. You go to work every single day. You have no clue what's going to walk through your door. You don't have a set schedule. You go to work, and for us, a good day is when really nothing happens. A bad day is when, like you just said, that life-threatening event happens. That's when the pressure kicks up. That's when you have to really rely on your education, your skill, your clinical acumen to really work on saving that person's life. And
well, I thank you. I hope that if I have to be rushed into an ER, I'm actually at the hands of you.
Or any one of us. At least in this city specifically, there are very good training programs, whether it's USC, UCLA, UC Irvine. Just in this local area here, we have a lot of good ER doctors coming out into the city just from the local area. So we're very fortunate in this city.
And I like that you're also separating and saying that it actually is a specialty.
It is.
To be an emergency doctor.
It is. Not everyone understands that. We have patients in the ER that'll ask us occasionally, "Oh, where's your office? Like, if I come see you?" And like, well, this is my office in the emergency department.
Welcome.
And those of us that choose to go into emergency medicine have made the decision that we're not going to have a private office, and the emergency department is going to be our primary area that we provide patient care.
A couple questions, doctor.
Sure.
Triage. What's a triage?
Triage is actually a French word that developed out of the need to take people, and actually goes back into the wartime, that had different severities of illness. In that case, would have been trauma. And then try to figure out who was in most need and who was in least need of immediate medical attention. And unfortunately, those that were not able to be saved at all. And so you actually tagged, okay, the toe tag, so to speak, with different colors, trying to figure out how to triage these different patients into different need classes.
Okay.
And so when you walk into a hospital and you walk into their emergency department, the role of the triage area, and most departments nowadays are still staffed with the triage nurse. There's some modalities that are changing that and putting a doctor in the triage area. to move the flow. But for the most part, it's usually a nurse that's in the triage area. And that nurse's responsibility is to, A, identify what the critical need is, and then triage that patient, which means determine, do they go back out in the waiting room and wait for another, half an hour before they get seen, or do they get rushed back immediately? Now, these are patients that are not coming in by ambulance. These are patients that are walking in the front door. And you'll be surprised what walks in the front door.
Oh, I can only imagine. No, but so for all of us that wait in an emergency room, because I asked Nurse Callie about the wait, behind the scenes we have no idea what's going on, that ambulances are carting in bodies that have been impaled and bleeding, bones broken.
I can tell you, when you're waiting out in the waiting room, there's nobody sitting in the back of that emergency department watching TV, drinking a cup of coffee. It is a highly active, environment, 24/7. And these are most of the large urban emergency departments, like at Glendale, Mentist, where we're busy 24/7, and we have a full staff and a full patient load